series for medical undergraduates by the Royal College of Surgeons of Edinburgh, and it's a program that the Royal College of Surgeons regional surgical advisors have put together for you who are currently not attending your medical schools and therefore having your training interrupted. We've got an exciting topic today, especially because lots of us at times wonder how we deal with neck lumps. And to give us his talk is consultant endocrine and general surgeon, Mr. Shad Khan. Shad is part of our consultant body at the Oxford University Hospital. He completed his training in London prior to moving across to the arguably the largest and the biggest adrenal program and endocrine unit in the country, in Oxford. He is a surgeon by training, but also he has a unique skill in that he is dual accredited as a consultant intensivist as well. So I'm really looking forward to his talk in relation to neck lumps. Just to give you a few details on housekeeping, there is a Q&A facility at the bottom of your panel. Use it to ask questions, and I shall try to answer some of them and keep the important ones, or those that you vote as the most popular, with your thumbs up sign, for Shad to answer at the end of the talk. So without much ado, I'll hand you over to Mr. Khan.
Thank you very much, Mike. Great pleasure to be here on this lovely day. Massive thanks, Mike, to yourself and to the admin team. This is a lot of work that goes into putting all this together, as I've realised. And it's a very exciting opportunity to be here with you all today. Thank you to the Royal College of Surgeons for allowing me to do this talk for you. So I've been asked to talk about neck lumps, which in my practice as a general and endocrine surgeon I come across regularly, and hopefully I can share some of that with you today, and you can learn a little bit about how we approach and how we manage these neck lumps. So first of all, why do we bother with these? Well, they're a very common reason to attend primary or secondary care. And in the grand scheme of where you end up in medicine, whether it's surgery, general medicine, general practice, pediatrics, or most subspecialties, you're going to come across neck lumps. It's probably worth bearing in mind that neck lumps are a real favourite of undergraduate exams and postgraduate exams, and they are likely to come up again and again. The differential for a neck lump is wide, so the advice is to be systematic and know your anatomy. Now, I know sometimes that word brings dread into some people, but we'll try and go through some real simple ways to approach a neck lump, and hopefully you can formulate a differential when you see a patient with a neck lump. So the approach is like in any lump or any examination we're doing. You're going to take a history. You're going to examine your patient. You're going to look at the biochemistry, that's the blood test, the radiology, the pathology, and then you're going to formulate a management plan. And we'll try and slowly walk our way through these and try and get this. The anatomy of the neck is as simple as this. You want to try and think about an anterior triangle and a posterior triangle. Now, clearly things do get a little more complicated than this, but ultimately here what you have is an anterior triangle made up of the inferior edge of your mandible, midline, and then coming up the anterior surface of this muscle here, which is your sternocleidomastoid. That is your anterior triangle. You then have your posterior triangle, which again is the posterior border of sternocleidomastoid, the clavicle, and then coming up the lateral side is going to be your anterior border of your trapezius. And these are the two key things you need to remember when you're approaching any neck lump, just to help break it down in your mind as to what you're after. Now, things in life, in surgery, are not sadly as simple as this, and things do get a little more complicated, but I'm going to try and convince you very quickly that the triangles are still here. So here we have mandible going across here, down the anterior border of sternocleidomastoid, and then coming up the midline. anything within this area here, whilst they will be broken down into other triangles that you can see written down here. You don't need to worry about that. At this stage, you're worrying about this being the anterior triangle. And the posterior triangle here again, we've got the posterior border of sternocleidomastoid, clavicle, and then anterior border of trapezius, and that's your posterior triangle. This becomes relevant here because then you can break down your differentials straight away just by knowing where the patient points to their neck. Here you can see in the posterior triangle first, we have a lot of lymph nodes, and those are a very important structure in the neck. We'll talk a bit more about those. Lower down here, we can have lymph nodes from primaries outside the ENT area, outside the face, from, for example, from the breast or the lung. In this area, we also have this abnormality called the cystic hygroma, which is a malformation of your lymphatics, if you like. Your subclavian aneurysm, which will also be down here, aneurysm of your subclavian artery, which will come across as a pulsatile mass, and a cervical rib, which is an extra rib, which occurs in about 1 in 200, 1 in 300 people, and can cause a lot of symptoms down your arm if it blocks the arteries and the brachial plexus. The anterior triangle, again, around over here, we're talking about lymph nodes, which can be inflammatory, neoplastic. Here are all the things that can come across. A few things I'll mention is the branchial cyst, again, another congenital one, an examiner's favorite, usually comes higher up in the neck. A thyroid lobe swelling, this is the area I specialize in, so we'll talk a little bit more about those, but thyroid, very, very common to know in your practice. And then a few smaller, rarer things that you might come across. Now, whilst the midline is technically part of your anterior triangle, it's worth thinking about midline lumps as slightly separate. And the main thing here that you want to look at is whether there are any lymph nodes or a thyroglossal duct cyst. Now, thyroglossal duct cyst is, again, a remnant embryologically. Your thyroid originally starts down at the base of the tongue and descends in embryological life until it finds its place in the neck. And the duct that connects it to the base of the tongue usually obliterates, but in those people that it doesn't, it can remain as a small lump that comes up. And you'll know this because when you ask the patient, when you're examining the patient, you get them to stick their tongue out, this thing will move. Lymph nodes of the neck get complicated. There are hundreds of lymph nodes within the neck, and you need a systematic way to approach them. Now, you'll learn different ways from different people. The way I was always taught, and the easiest way was standing behind the patient. You start at the chin, you work across the mandible, you run down the anterior cervical chain, back along the clavicle, and then up the posterior chain, and then have a feel around the posterior and preauricular ones. The function of lymph nodes, I'm sure you will know, to drain fluid around the body and to be involved in the immune function. So we get on to what we're really here for now. How do you take a history of someone with a neck lump? The first thing is the patient will usually come in and say, I've got a lump, here it is. And it's very important to try and really have a good look as to where they're pointing at and know what the lump is. That will tell you immediately, roughly, give you an idea as to what your differential is going to be. You're going to take note of the age of the patient. Like in most things, the older you get, the higher chance of cancer, but be aware, like almost everything in medicine, there are exceptions, and young people will also get cancers. You're going to ask about duration of symptoms and any change in size of this lump, where rapid changes are slightly more concerning. We'll take a past medical history. Things like smoking, previous radiation exposure are all relevant. Any recent travel, or any family history of malignancy, which might be relevant here. There are red flags, and these are listed here, things that you are immediately going to be concerned about and might want to consider referring across to secondary service along the 2-week wait cancer pathway to get more urgent review. So examining the patient, like you would do in anyone, this is a general approach that you would do for any patient you're examining. You will wash your hands and wear an appropriate level of protection. You will introduce yourself and explain what you're going to do. You're going to gain consent from the patient, and then you're going to position the patient how you're going to best examine them, and we'll talk about that. And then you're going to inspect around the patient and begin your process. With examination of the neck, it's really important that the patient understand what you're doing, because this is one of the few examinations where you're not going to be looking at the patient while you're doing this, and you're not going to be able to see their response. You're going to inspect their neck from the front, get an idea as to what the lump is, where the lump is, and look at skin changes, scars, things like that that you're going to see from the front. You're then going to stand behind the patient in this maneuver you can see up in the top right corner, where your hands go around the patient's neck, and you're really having a good feel of the lump itself and the surrounding structures, and whether there are any other lumps that the patient has not felt. This can be quite uncomfortable and a bit unusual because you're not looking directly at the patient. You're essentially standing behind them with your hands around their neck to go softly, go slowly, and make sure you keep asking if they're comfortable with what you're doing. The second patient here is, whilst the technique is clearly a misuse, just massaging this patient who's enjoying it far too much. But you get an idea standing behind the patient and keeping an eye as to what you're doing. So your aim is to describe the lump. There are, again, many ways of doing this. I was always taught get an idea as to the site, the size, the shape, the scars, and any skin changes. You want to check, does it move on swallowing, or as we've said, will you stick your tongue out? You want to have a rough idea as to the consistency of the lump, and that really will only come with time and experience. But is it a hard, solid lump, or does it feel soft and a fatty lump? Does it feel like it's full of fluid, and if you stuck a needle in, you'd get a lot of liquid out? You're going to feel the temperature of the lump. Could this be an infection, an abscess? You're going to transilluminate the lump. You can see a lovely picture here of what you talked about before, a cystic hygroma, which is described as brilliantly transilluminating. Is it a pulsatile lump? Before you go around taking any biopsies or anything like that, you always want to check that this lump is not a potential vessel, and you're going to auscultate for bruise. Radiology and investigations, well, there are quite a few available in our arsenal. Ultrasound is usually a first line. It helps delineate the nature of the lump, gives you a good idea as to what it's made of. It's cheap, and it's easily accessible anywhere in the world, really. It's very user dependent. You want a radiologist or a radiographer, whoever does your scans, to be well versed with neck imaging and neck anatomy, rather than someone who's just doing it every now and again. And the real beauty with ultrasound is that it can be combined with taking a fine needle aspirate or a core biopsy then and there, if the radiologist or radiographer feels it's appropriate, and you can sometimes within a day get an answer as to what is going on. We have availability of cross-sectional imaging in the form of CT and MRI. This allows for anyone to look at a scan. It gives excellent anatomical detail, but it doesn't allow you to get a biopsy as to exactly what's going on, and that is very useful in neck examinations. They're a little more expensive, and obviously we have to consider that a CT gives a small dose of radiation. MRI, of course, is not suitable for everyone. Those with claustrophobia or metalwork might not be able to have that. Depending on what you found so far, you might order some specialist tests. If you think it's vascular in nature, an angiography might be useful. Sometimes we look down the nose and into the pharynx and larynx with a nasendoscope to see if there's any other lumps on the inside that might be contributing, or possibly any vocal cord problems. If anyone comes in with a voice problem, you'd always want to have a look at their vocal cords and ensure there are no nerve injuries going on there. And sometimes a thyroid uptake scan can be useful, which is a functional scan to see if there is areas of overactive thyroid or underactive thyroid. Pathology is very important, and this is probably one of the main things we rely on. You want a fine needle aspirate or a core biopsy of some sort of material to send to the pathologist, and it depends on what you think it is before you decide on that. The fine needle is usually enough to help get a diagnosis, but it's not always. And we're always taught to be very wary of taking a fine needle aspirate from a lymph node, because it's very difficult to diagnose things like lymphoma, where often a core biopsy is needed, and sometimes even that's not enough, and we're actually asked to come along and remove an entire node from the neck for the pathologist to have a look at. Treatment, it's very difficult to talk about treatment because it depends very much on the diagnosis. It's worth mentioning here that you'll hear this MDT referral again and again, and it's very important in your exams to mention this, that any suspected or confirmed case of cancer should be discussed in an MDT. That's not to tell you, the purpose of the MDT is not to tell you what to do, but just to help ratify decisions and ensure everyone is involved in the process. Benign lumps in the neck can be left alone or removed. And the main reasons you'd want to remove them is if cosmetically on the neck, people don't find it cosmetically very nice, or if they're causing some sort of compression on the neck. So that's a lot of information. So I'm going to go through a quick case history just to bring this all together. We've got a 45-year-old female who's had a rapid onset lump on the left side of her neck for about 3 months. She's quite fit and healthy, has a bit of asthma, smokes every now and again, no family history of note. So it's a very typical patient that we might get sent to us with a neck lump. So you go on to examine, and you find this. So here, I've given you some of the findings. I'm going to try and convince you that this is probably in the anterior triangle. If we say the sternocleidomastoid is coming down here. So this is probably just in the anterior triangle. It's a good sized lump, measuring about 4 by 4 centimeters. Can't see any other scars in the neck other than the natural skin creases. And there are no other overlying skin changes. It's a firm, hard mass that moves up on swallowing. Now, moving up on swelling is important because it suggests it is related to the thyroid. It does not illuminate, and when we did a nasendoscopy, it was completely normal with normal movement of the vocal cords. So the question here is, what do we do next? We've examined the patient, we've taken the history, we've got an idea as to what's going on. And I think at this time, we're going to try and talk to you about the differentials, what's going on. So we've said we're in the anterior triangle. So we're going to run down in your mind, you're going to run down this list of lymph nodes, of branchial cysts, of thyroid swellings, pharyngeal pouches, and all things like that. You're going to get a rough idea as to what one of those it could be as you target your investigations. So I think we're going to do a poll at the moment and see what would you do next. Would you, with this anterior neck lump, recommend an ultrasound, recommend a CT scan, an MRI scan, or a thyroid uptake scan? So go ahead and pop on whatever you want. I'll give 30 seconds. It's worth mentioning here, what I'm going to ask you is the most appropriate scan. And you're going to get used to this because in your exams, you're going to get to a level of knowledge where you can make an argument for pretty much any one of those, with some being more right than the others. And what we're looking for is the one that's the most right, the one that in an exam, a verbal exam, you could really justify your answer. There's no real wrong answer here. But I'm just interested at this stage what you would do. So good. So we have the results there. I hope you can see. About 74% felt an ultrasound was good, 9% felt CT, 5% MRI, and 12% a thyroid uptake scan. I think here at this stage, my own personal preference would be to go with an ultrasound scan. The reason here is we feel like we've got a lump that's probably from the thyroid. We're not certain yet, but it's a good bet for it. And the real thing we want now, moving forward, is get a diagnosis as to is it coming from the thyroid or not, and then with the ultrasound, as I mentioned earlier, it really gives you the advantage of getting a biopsy if needed. The other tool that the radiologists have is this ability to look at a lump in the neck and grade it for you. And in particular for the thyroid, we have all sorts of classifications, but this classification I've written down here of the U scoring. And you'll get used to these scores out of 5 that pathologists and radiologists and clinicians are obsessed with, where we think 5 is a terrible thing and it's probably cancer, and a 1 is not really sure what's going on. So the radiologist has very kindly done this ultrasound and said there's a 4 by 4 centimeter mass which is arising from the thyroid, and he said it's radiologically concerning for a malignancy. Now, as I said, there's all sorts of worrying features and signs, but here are the things that he's outlined, the things that make him be concerned. Hypoechoic nodule within the thyroid, which means it's darker than the rest of the thyroid. It's an irregular outline. So if I try and come to you here, this is a very smooth outline, and this is your common carotid artery, so it's expected to have a very smooth outline. But here, in this lump here, we've got slightly less smooth outline going all the way around here, and we call that quite irregular. This is a solid lump, it's not full of fluid, which is a little more concerning. It's taller than wide, something that thyroid surgery we're obsessed with. And it's got echogenic focus, and all these things are quite concerning that this might be a thyroid cancer. Very importantly, he said there is no localized lymph nodes involved, which is very important because the thyroid would metastasize to, or some thyroid could metastasize to the local lymph node. So we go on and we could ask our radiologist then and there to perform a fine needle aspirate, or clinically ourselves, we could do that in a clinic and send it off to the lab. And again, as I said, we get a score out of 1 to 5 where the pathologist looks down a microscope and tells us what we've got. And these are the typical gradings that you get for almost all lumps that we take the samples from. And in this patient, we've got this Thy5, which would suggest that as well as the radiology being very concerning, the fine needle aspirate is also very concerning for thyroid cancer. So now we're on to the stage of what do we do next? And as I tried to mention before, we're worried this is cancer. We would want to take this to a multidisciplinary meeting. We present the case, and as the clinician looking after the patient, we would say, I think this patient needs a total thyroidectomy. And that should be ratified by everyone else, and everyone else should agree, the radiologist, the pathologist, other members of the team, such as the oncologist, and any other surgeons should all be on the same page when you offer a treatment. And then you can go back to the patient and discuss it with them and say, this has gone through a meeting, and this is the best recommendation we can give. After an operation to remove the entire thyroid, we again discuss the histology in our meeting where the pathologist tells us what we found, and then there's an offer of whether any further treatment for this cancer is required. In thyroid, we don't give chemotherapy really as routine, but we do sometimes give radioactive iodine. The realm of whether we give iodine or not is probably outside the remit of this talk, but in what we call medium or high risk thyroid cancers, we would consider giving radioactive iodine therapy. So a quick summary, so I'm probably running over time I think, is just to say that neck masses are quite common. Approach them systematically, have a good understanding of the anatomy, really try and work out very early whether this is an anterior triangle, a posterior triangle, whether it's in the midline, and then really target your investigations, your blood tests, your radiology, your pathology, to try and work out what that could be from there and have a good differential in your mind. I'm aware I didn't talk much about biochemistry. In neck lumps, it's a bit more difficult. We can go through that if the question so asked. I was quite keen not to stay too much on thyroid because whilst that's the area I look after, there are many other courses for neck lumps, and therefore I didn't want to go too much into that, but we can talk about that. But hopefully there, you've got a good understanding as to what neck lumps are, what the differential are, and how to approach them. Neck examinations are very common, undergraduate and postgraduate. You will come across them, so just have a good understanding as to how you approach them in your mind and what you're trying to achieve. Good. Over to you, Mike.
Excellent, Shad. That was very clear and succinct, and just what I expected from you, really. There have been quite a few questions with regards to examination and issues related to lumps that move with swallowing. And I think maybe you could just go through what you mentioned about the thyroglossal cyst and then compare that with how a thyroid would differ and the signs you would elicit by asking a patient to swallow. But in addition to that, there's a question that one of our attendees posed as to, are there other lumps in the neck that could move with swallowing? And if so, how would you differentiate all of that?
Yeah, it's a very good question. And no, it's not an easy one. We typically say if you just put your hand on your neck and take a glass of water, it's difficult to swallow just on command, and to swallow, you'll feel everything moving up. And that would suggest that it is part of the thyroid. Other lumps stuck to thyroid or in the close vicinity may also move up. So whilst clinical examination gives you a lot of information, it doesn't tell you everything, which is why we rely on this triple assessment of clinical examination, ultrasound, followed by pathology as well. Thyroglossal cysts are a little more difficult. They're a bit easier to diagnose because they're usually higher up in the midline. And you get this, as we said, they're usually attached to the base of the tongue. So if you get them to open them out, stick their tongue out, it should move, when you do that, it should move upwards as if your tongue protrudes, as it's attached to the base of the tongue, so you can see it moving upwards. And it's the kind of thing, once you see it once, or maybe even just YouTube a video, it really gives you a good idea as to what you're looking for. The midline lumps are usually going to be a thyroglossal cyst for the purpose of pure exams. They could be, of course, other things, lymph nodes, for example, or a thyroid isthmus. But a true midline lump that's slightly higher up, you're going to find it's probably going to be a thyroglossal cyst. So have that in your differential at all times for midline.
And does a thyroglossal cyst necessarily have to be in the midline always, or could it even?
You know, absolutely right. It can be slightly off to the side. We always talk about what are common things being common, so it can be slightly more to one side, but generally you'll find them in the midline. I think it'd be very hard done by an examiner brought a thyroglossal cyst off to the side and said that's what it was. I think even for me that would be much lower on my differential for a neck lump which was off to the side.
Another very important question that one of the attendees just answered, and I'm going to pop that up the list simply because I think it's important. especially for medical students to understand this. Lymph nodes are pretty common in the neck, especially if you have conditions in your scalp that are skin related. You can have quite a lot of lymph nodes from that field, as well as from your chest and upper limbs.
Mm-hmm.
So finding lymph nodes clinically when you examine a patient is not that unusual. But when would you worry about it? When would you think it's a problem that needs further investigations?
Yeah.
And then to follow that up, what are the investigations you would do?
Well,
a lymph node that you're worried about?
Absolutely. I think lymph nodes are probably one of the commonest reasons to get lumps in the neck. They occur at all stages of life. And I think part of it is you get used to examining lymph nodes and knowing what are slightly more worrying. We can't see everyone with a lymph node because people get lymph nodes for all sorts of reasons. As you said, you get a cold, a scalp infection, a cancer. So the differential is so wide. So we usually tell people that if you get a lymph node, keep an eye on it. So the GPs, for example, will keep an eye on it between 2 to 6 weeks. If it persists after that time, we would normally want to see them and start to investigate things a little bit more. And then that way we would get the ball rolling with examining them, getting them referred to us, examining them, scanning them, doing some blood tests, things like that. So the theory is if it's an infection, they will die down in time. If those that don't, we would want that investigated a bit further. And just quickly, I'm going to quickly share my slide again and just show you if I can. This diagram here, which is looking at the lymph nodes in the neck and where they drain. So the next stage on is, as well as finding the abnormal lymph nodes in the neck, you're going to have a rough idea in your mind about what drains that area. So scalp infections may give these pre and post auricular ones. Our thyroid worrying cancers would be more in the anterior and posterior triangle. So you get a rough idea as to where the problematic lymph nodes are and what drains what area.
Great. I think that's very clear. The other question that keeps popping up quite frequently, we've got loads of questions just pouring in, is imaging. Now, you did mention ultrasound, you mentioned CT, so there have been quite a few questions asking when would you choose CT, what's the role of MRI, and maybe if you could just talk through the sequence of how you'd approach that.
Well, these are all very good questions, and I must say things get quite complex. So you go from one unit to another, you might find things change. Here in Oxford, we're very keen on ultrasound. We have these one-stop clinics where we have sometimes sonographers in clinic with us, so we have very easy access to those things. CT scan still has a role for those things which are probably outside the thyroid. If you've got thyroid cancers, you want to see what extent they've gone to. You want to have a look at around other areas in the head and neck. CT and MRI become very useful. MRI gives you really good anatomical detail, as does CT, without the radiation. So if they can tolerate that, that's usually our next go-to procedure. Thyroid uptake scans, slightly off topic here. I put that in as a curveball because what you want is you're looking for people to be overactive before you do uptake scans, and then you're trying to decide whether or not the whole gland is overactive, for example, in the Graves, or whether there's just a certain nodule, for example, that you need to treat in order to get them better. So thyroid uptake scans are more functional scans. CT and MRI, no one's going to really penalize you, but you in these exams and in these OSCEs you go to, you need to have a reason why, and that's what an examiner is looking for. You can say to me, as a first time, I'd like to do an MRI, and the answer is, when the question comes to you, why do you want to do that? As long as you can give a good answer, well, because I'm not sure where this is coming from, I'm not worried about doing a biopsy at the moment, and what I'd like to do is get a really good look at the anatomy of this area. But I must say, if you're thinking that it's a thyroid lump, the first line is usually going to be an ultrasound. So once you've done your examination, your history, your examination, you get a rough idea as to what you think you're looking at. That's when you would tailor your imaging accordingly.
Great. That's another question. And because we are talking to medical students, I think it's important that we try and get this across to them. It's a very basic one, but I think it's hugely important. And that it is focused around when you will be able to differentiate between a lump that's solid and a lump that's cystic. So there are questions, many questions about fluctuation, cross fluctuation, trans-elimination,
Yeah.
And also the difference between that and a solid lump. So maybe you could just talk through that.
Absolutely. So the honest, simple answer is it's very difficult. Even clinically, you get it wrong sometimes. You think something's really a very hard, worrying-looking lump, and as soon as the radiologist puts a scan, he says, no, it's just a tense cyst full of fluid, and actually it doesn't feel like that. It comes down to experiences, is the sad truth. You feel enough of these, and you'll get an idea as to what feels more solid and what feels more like you can blot it like a little balloon underneath the neck. And there's really no answer, no easy answer. It's the same with lymph nodes. People come and say, we have some of our junior doctors come and say, how do you know that lymph node feels worrying and malignant, and how do you know it doesn't feel like that? And people can say, oh, well, you know, the benign lymph nodes are just soft and rubbery, but what does soft and rubbery feel like? Well, until you felt 20, 30, and felt 20 or 30 malignant ones, you won't really have an idea. So all you're doing really is trying to get out there, examine people's necks when they've got our pathology, and correlate that with the ultrasound, and you get an idea in your head as to what feels like that's a solid lump, and the scan said, yes, it's solid, now I've got an idea, and what feels like a thyroid cyst, or just a benign lymph node, or something, a thyroglossal cyst. Once you've felt them a few times, you'll become more and more comfortable with knowing which is which. One important thing, particularly going forward, obviously clinically you want to be correct when you're examining your patients, but just for the purpose of for your exams, I must say the end diagnosis is less important. It's more the process you use to get there. So if you say something's a cystic lump when it turns out it's a solid lump, you're not going to lose that much. You're going to lose maybe 1 or 2 little points, but actually the reality is once you've done the whole process in getting you there, that's where you build up the majority of the marks. And I don't mind saying, to a certain degree, when the examiner's been listening to 30 medical students talk about the same thing, they might have switched off to a certain degree, and actually all they're looking for is this a confident person who's made the patient comfortable, who's examined systematically, and if you are, you're going to pass that station one way or the other. And all you want to do is then put together a sensible differential. Going forward in your exams, postgraduate exams, yes, you want to get a bit more clinically accurate and start to really show what you can do, and that will come with time. But at the moment, these are all good questions, but at the moment, I think what I'd say is experience, time and experience, and the rest will just come with time.
I couldn't agree with you more. There are lots of questions that are very subject matter orientated, as in related to thyroid cancer, thyroglossal cysts, and pathology there. And I think the topic here we're covering is just a general approach to neck clumps, and therefore I'm not going to put those questions forward because we're going to cover those in future webinars. But just to wrap up, if you've got a neck clump and you are worried about it, if you could just summarize the investigations in sequence that you would do from blood tests to imaging, because again, that's a common theme I'm seeing here, like what's the first line investigation? There isn't a first line investigation unless you have got something very definite in your mind as a probable diagnosis, is my answer really.
All right, so I'll run you through quickly. So someone comes to you with a neck clump, it doesn't matter age, size, or anything like that. Your general thought process is to examine them. You're going to get an idea in your head as to what that is. You're going to order some blood tests, and those are going to be the simple things from full blood count, and you're looking for, is the patient anemic, to give you an idea, is there something malignant going on? You're looking for the white cell count and seeing is there particularly high or particularly low, which might be concerning. You're going to, if you're thinking about things like lymphoma, you might want more specialist tests like an LDH, a lactate dehydrogenase, which can be important. You want to check your thyroid functions if you're at all thinking this might be a thyroid lump. So those are the simple blood tests you're going to organize. Scans, I'd still say for most people, in the vast majority, the first line you're going to go with is an ultrasound, plus minus a fine needle aspirate. That comes as a package, and it gives you an idea, first of all, what the sonographer or radiologist thinks the lump is. And it will also get you a bit of tissue from within that to help confirm the radiological findings and your clinical findings. And that, very simply put together, is enough for the vast majority of neck clumps to really give you a good idea as to what you're dealing with. And from then on, you can start planning your management and more specialist tests, such as, but do you need a CT? Do you need an MRI? Do you need uptake scans and things like that? But this is a simple blood test and an ultrasound plus minus fine needle aspirate will almost certainly give you the vast majority of the answers that you need.
Great, that's wonderful, Shad, and thank you very much for that real overall introduction to how you approach a neck clump. So just to wrap up, guys, we've got a talk next Tuesday. It's on the presentation and management of bowel ischemia. And Stephen Boyce, colorectal surgeon,